Chapter 4 and 5 go over the physiological and psychosocial changes during pregnancy, and they talk about promoting a healthy pregnancy and the prenatal assessment. ATI chapters that go along with this are chapters 3, 4, and 5. So there's many system changes, particularly in the reproductive system. The uterus, the cervix, the vagina, and the breasts are all changing during pregnancy. The uterus enlarges from about 70 grams to about 1,100 grams, so about 20 times the size of a non-pregnant uterus. Obviously, a lot of the increased blood flow is going to the uterus during pregnancy. The cervix is that bottom neck of the uterus, like we talked about in the first slide deck. It's the opening of the uterus across from so when we talk about the fundus, that's the top of the uterus, the cervix is the bottom. So the part that opens up, that dilates, that thins out, and that stretches so a fetus can go through and actually be born vaginally. So what happens during pregnancy is the cervix softens, which is called Goodall's sign, and becomes bluish, which is called Chadwick's sign. This happens very early on, and providers can actually see and feel that, so they're considered a probable sign of pregnancy. There's also increased mucus. There's a mucus plug that basically sort of stops up the bottom of the cervix to create a barrier between the fetus and any outside organisms that would cause it any issues or infection. So again, Goodall's sign, Chadwick's sign, those are all signs that a provider might see during an internal exam in the cervix. The vagina has increased vascularity, thickened mucosa, and more white discharge. The breasts enlarge, the areola darkens. Usually colostrum can be seen by the second trimester. They're larger than normal, they're full, they can be tingly, increased sensitivity, enlargement, fullness, tingling. All of these signs are usually signs that a woman will feel. They're usually one of the first signs of pregnancy. They're considered a presumptive sign of pregnancy. So we'll talk about that in a little bit. Presumptive, probable, and positive signs of pregnancy, just so you have a clearer understanding of what those are.
There's general body system changes too. In the cardiovascular system, cardiac output increases about 30 to 50%, and blood volume increases about 40 to 50% by term to meet greater metabolic needs, the greater metabolic needs of pregnancy. You want to educate women on signs of preeclampsia, which would be around 20 weeks having higher blood pressure than even normal. Pregnancy spacing is also something that's necessary to educate women about because of all this blood volume, in addition to any kind of vaginal or perineal repairs or sores that really need time to heal, the heart and the left ventricle also needs about 6 weeks to really get back to its pre-pregnancy size because of all that extra blood volume that's pumping through the placenta to the infant or to the fetus. There's also something called anemia, physiological anemia of pregnancy, or pseudoanemia, because the blood volume increases about 40 to 50%, but the red blood cells only increase about 25%. There's a disconnect in the hematocrit, so you want to make sure that you understand that that's something that can happen when you're looking at blood work, just because of that dilution. Also, clotting factors rise in pregnancy. Women are at higher risk of DVTs and PEs. You want to educate pregnant patients to always be careful of lying supine because of supine hypotension. So that inferior vena cava can become compressed. Women can get low blood pressure, diaphoresis. You want to teach patients to lie on their left side or in semi-Fowlers, even in the OR or in the operating room. When they need them to be fairly supine for the surgery, you'll always notice that there's a wedge under their hip to relieve that direct pressure. You want to educate women on DVT risks, and again, monitoring for signs of preeclampsia, which we'll talk about later on in the complications slide deck, but that's high blood pressure, any kind of vision changes, protein in their urine. There's changes in the respiratory system as well because maternal oxygen needs increase. And also that the job of the placenta is sort of shunting that oxygenation and taking away the carbon dioxide from the fetus through the placenta. So there's respiratory changes. Nursing education that's important for that is respiratory rate increases and total lung capacity decreases, but you want women to recognize that if they're ever short of breath, especially early on or in the second trimester, that's something that they want to show. They want to tell their provider about, even in the third trimester. You just don't want to assume that it's pregnancy related or it's because, the gravid uterus is, pushing on the diaphragm. Shortness of breath is always something that needs to be investigated just so you can rule out anything else more detrimental, such as a PE or asthma or any kind of other respiratory issues. So GI system, there's inflammation is common due to increased blood supply to the gums. Motility is decreased, so a lot of women will have constipation as one of their complaints, heartburn, nausea and vomiting is also possible. And again, they think that's because of the hormone HCG or the human chorionic gonadotropin. Usually that subsides in the second trimester, but not always. For the renal system, the filtration rate increases. The amount of urine produced is the same. Urinary frequency is common during pregnancy, especially early on, and then again in the late third trimester because of that pressure on the bladder. Mom, again, is filtering waste for fetus and herself, so that's why that glomerular filtration rate increases. And a mild glucosuria or glucose in the urine is common. So for joints, there could be a little curvature of her spine. There's joint relaxin. The hormone is responsible for some joint laxity, pelvic discomfort. Usually any joint or hip pain is relieved once the fetus is born. There's also skin changes that can happen because of the hormones. Hyperpigmentation, linea nigra, chloasma, and melasma are interchangeable if you hear those words. Striae gravidarum is stretch marks. For nursing education, it's important for you to know about sunscreen usage, about relaying to patients that they need to use sunscreen. Most of the chloasma and melasma, that's transient. Stretch marks really are permanent. They do lighten. They become sort of like a white or a silvery color, but they're a permanent side effect of any kind of skin stretching, which obviously happens during pregnancy. So these are just images of the stretch marks, the facial chloasma or melasma. Sometimes you'll hear people call it the mask of pregnancy, an angioma. And then this is this linea nigra that, again, it can fade after pregnancy, but it might be something that you see stick around. So when we talk about signs of pregnancy, you can put them into a category of 3, presumptive, probable, and positive. So presumptive you can think of as subjective or signs that a patient might experience. Probable or objective or signs a provider might observe, and positive are signs that can only be attributed to a fetus. So we say that because amenorrhea or not getting your period, being nauseous, having to pee a lot, having breast tenderness, all of these things can be attributed to something else, right? You could have a GI bug, you could be exercising too much or not eating a lot, and you could have a UTI. All of these things can be attributed to something else. So they're a presumptive sign of pregnancy. But not necessarily, indicative of pregnancy. Probable signs are signs that a provider can see internally. So Chadwick's sign and Goodall's sign, or a positive pregnancy test. Those Chadwick's sign and Goodall's sign, again, are when the cervix is softer and has a bluish color because of blood supply. And again, that's something that can only be seen on an internal exam. A positive pregnancy test, so we talked about that HCG is what they're looking at when you do a home pregnancy test. It's a probable sign of pregnancy. It is used as a diagnostic tool, but we only consider it a probable sign because HCG is very similar to luteinizing hormone, which men have, and some malignant germ cell tumors can produce HCG. So it is used for diagnostic purposes, but it's not a positive sign of pregnancy. I just want you guys to understand the difference. Positive signs of pregnancy are signs that can only be attributed to a fetus. So if you hear fetal heart rate by a Doppler, if you visualize fetal cardiac activity by internal ultrasound, or fetal movement is felt by a physician, midwife, or provider, then that can be a positive sign of pregnancy. Interestingly enough, also a baby being born. So retroactively, when a baby comes out, you can be like, yep, that was a positive sign of pregnancy. So it's important for you guys to know that pelvic ultrasounds or the transvaginal ultrasounds, those internal ultrasounds, are usually done in the first trimester to diagnose pregnancy, to obtain a due date, rule out any abnormalities. Patients should have an empty bladder for that. For the abdominal ultrasound or the Doppler, you need to have a full bladder. That will help with those sound waves to be able to hear what you need to hear and to see what you need to see. For the external ultrasounds, that's something that you need to know as nurses. So for nursing assessment of psychosocial changes, we always have to assess interpersonal violence. We'll do it on every floor of the hospital. It's especially important in pregnancy because pregnancy is a rather dangerous time for people. So there's a January 2025 study that said deaths by homicide and suicide are the leading causes of maternal death in our country. So you can click on that to read it. It was just published this year. It's interesting because when we look at maternal mortality, like when the CDC looks at maternal mortality or the state of Delaware does, homicide and suicide are not counted in those reasons. So when we talked about cardiovascular reasons, sepsis, infection, those are all maternal mortality sort of classifications, and as of right now, homicide and suicide are not in that. So it's a very important and sort of interesting article to recognize that interpersonal violence does happen, and pregnancy sort of is a more dangerous time for many women. So you want to assess this using trauma-informed care, any kind of mental health or trauma screening. You want to use therapeutic communication that's free from blame or judgment. A lot of hospital systems will have it on their admissions where you're assessing for mental health, substance use disorder, any kind of social determinants of health, access to care, transportation, all very important things when we are trying to figure out what we can offer our patients resource-wise. And then again, we've talked about there's pregnancy-related deaths that are, causative. They're because of the pregnancy. And then there's pregnancy-associated deaths. And pregnancy-associated drug overdose deaths, when you look at that, they're highest in our state. So it's important to read, I would read that article. It's important to know that you really want to give people the resources that they need. You want to do it in a therapeutic way that's free of any blame or judgment. We do see babies with neonatal abstinence syndrome in clinical, so you want to be able to have been exposed to that and to know how to talk to people because, you will see it in the clinical setting, and you want to be able to share resources for people, and you want to be able to give them objective care.
So in promoting a healthy pregnancy and prenatal assessment is Chapter 5. What you will talk about with your patient is, how to choose a provider, an OBGYN, certified nurse midwife, women's health nurse practitioner. Most of what we have around here are OBGYNs. We do have certified nurse midwives. We have women's health nurse practitioners. They don't always have hospital privileges. It depends on the system that you're using. We do have a birth center in Delaware where there's certified nurse midwives, and they are close to a hospital. So it just depends on, what your family and what you are choosing to do, how you want to go through your pregnancy. If you're low risk, if you're high risk, it just depends. It's personal choice. At the first visit, as early as possible, you want to complete a health history with biographical data, medical and psychosocial history, interpersonal violence assessment, current pregnancy assessment, obstetrical history, any kind of comorbidities or complications. You want to talk about their plan. You want to educate them. So if a woman's coming to a pregnancy and she's already diabetic or she already has hypertension, those are things that are going to change the course of that pregnancy. So those are things that you want to know at that first visit or as early as possible. So in these next slides, we'll talk about EDD, which is estimated date of delivery. You might see estimated date of confinement. All of those just mean due date. GTPAL we'll talk about. That's gravida, term pregnancies, preterm pregnancies, abortions, and living children. We'll talk about labs that are necessary for prenatal patients, and we'll talk about the subsequent visits. So most of the time for low-risk women, you're going to be seen about monthly until about 28 weeks. And then between weeks 28 and 36, you're going to be seen every 2 weeks, and then weekly 36, 37, 38, 39, unless you're high risk. And that could be different. These are just generalities, but for our purposes, for this class, that's what you want to look at for a low risk, typical pregnant patient. So estimated date of delivery. Pregnancy is calculated from the first day of the last period to delivery. So we talked about, even though you're not ovulating until about day 10 to 14, even though fertilization doesn't happen for a couple of days after that, even though implantation doesn't happen for a couple of days after that, pregnancy is calculated from the first day of your period. So that's assuming a 28-day cycle, and it's about 280 days total, or 40 weeks, which again is 3 trimesters, so about 13 and some change, 13 weeks in each of those trimesters. Nagel's rule for the due date is subtracting 3 months, adding 7 days, and changing the year. So, for example, if your period was July 14th, 2025, you're going to go back 3 months. So, June 14th, May 14th, April 14th, 2025. You're going to add 7 days, April 21, and you're going to add a year because we're in July, right? It's going to be the next year. So you always want to be careful with January, February, and March periods because obviously those babies might be born in that same year. And we'll practice that in class, and that's not going to be something that you're going to have 10 questions on, but it is something that you should be able to estimate. And again, it's an estimate. Not everyone has a 28-day cycle. Not everyone has a regular cycle. But in general, that gives providers an idea of when to expect an infant. So again, your period's July, the last period you had, first day, was July 14th, 2025. You go back 3 months. So June 14th, May 14th, April 14th. You add 7 days, April 21st, and you add a year. So April 21st, 2026 is your due date, which is about 280 days or 40 weeks from that last menstrual cycle, the first day of your last period. So when we talk about GTPAL, gravity is the number of pregnancies regardless of the outcome. Parity or gravidity is number of pregnancies regardless of outcome. Parity is pregnancies reaching 20 weeks and 0 days regardless of the outcome. So, for example, a G1P1 is 1 pregnancy and 1 delivery beyond 20 weeks. It's further explained with outcomes. So, G1P1 is she had 1 pregnancy, she delivered beyond 20 weeks. The TPAL just sort of describes that birth or that para. So gravida is total number of pregnancies. T is term deliveries. 37 weeks and 0 days is a term baby. Preterm deliveries is anything from 20 weeks pregnant to 36 weeks and 6 days. Abortions, so spontaneous abortion, which equals miscarriage, or therapeutic or elective abortion, up to 19 weeks and 6 days. Anything is considered an abortion, whether it's on purpose, whether it's spontaneous, anything up to 19 weeks, 6 days. And then L is number of living children. I'll have to fix that. So I put N, but it's L. So, for example, a pregnant woman comes to the office for her initial prenatal visit. She's had 6 pregnancies. So you have to, right off the bat, you have to write down, she's pregnant right now. So that's most of the time what students forget. They forget that she is a pregnant person. So right now, that's 1. She's had 6 pregnancies. Okay, well, so she's a G7. This lady's pregnant right now, and she's had 6 pregnancies. She's a G7. So she's 36 years old. That's just extra. That number doesn't mean anything to us. She's had 1 therapeutic abortion at 6 weeks gestation. Last year, she had 1 spontaneous abortion at 12 weeks. She's had 4 live births. 1 child was born at 28 weeks and didn't survive. The others were full term. So we're looking at a woman that's G7, T3 for her 3 term babies, P1 for her one preterm baby that she had at 28 weeks. Abortions, 2, because she had one therapeutic abortion at 6 weeks, and last year she had one spontaneous abortion at 12 weeks. So her abortions is 2, and her living is 3, because she had those 4 live births and 3 children are still living. Again, we'll practice this in class. The book explains it a little bit wrong, so I would just listen to how we do it in class. I believe it says preterm pregnancies as opposed to deliveries, but the T, P, A, and L is term pregnancies, preterm or term deliveries, preterm deliveries, abortions, and then the L is number of living children. So we'll talk about it in class, but that's basically GTPAL. Again, you're going to have 1 or 2 questions on this. You'll have 1 or 2 questions on the first big test. You'll have 1 or 2 questions on the final. It's something that you need to figure out. It's not going to be a large portion of the class, but it is part of the pregnancy assessment. So, prenatal labs are another part of your prenatal assessment that you're going to have to understand. Most women are going to get a complete blood count as soon as possible. They're assessing for anemia, infections, any kind of clotting disorders, blood type, RH, and antibody screen. So you want to know what type of blood someone has, and you want to know any kind of risks for the fetus. So if you are type A, the RH factor is if you are A positive or if you are A negative. So if you are A positive, then you have that RH factor or that D antigen. About 85% of the world has that extra antigen. So that's considered A positive. If you don't have it, then you're considered A negative or O negative. Whatever your blood type is, the RH factor is just another antigen that they found. It's called the D antigen. So what can happen is if a mother is a negative blood type, she has, a husband or a partner that has a positive blood type, she has a chance of having a positive baby. Most of the time for the first baby, there's not going to be any sort of reaction. Her body doesn't have time to make antibodies to have any kind of reaction against that. Where that comes into play is when you give birth, when you have a delivery, when you have a trauma, when that placental membrane that we've talked about somehow becomes compromised, which can happen during labor because, it's sort of, you go through the labor process, there is going to be sort of like an opening to that. The body can create antibodies and sort of remember that. And then the next pregnancy, if there was another positive baby, the woman's body would remember and be like, oh, well, this is an infection. I need to get rid of this infection. That's how the body would treat it. So we have something that we can do about that called RhoGAM. It's made from human blood. And it's basically teaching the woman's body not to make those permanent antibodies, and so she doesn't have that reaction. There's something called fetalis or hyperbilirubinemia that can happen. So getting prenatal labs are going to be an important part of your prenatal assessment as well. In the first and third trimester, women are going to get a complete blood count just to see, any issues with clotting, assessing for anemia, any kind of infections. They're also going to get a blood type and screen and an antibody screen, and that determines mom's blood type and any risk for the fetus developing fetalis or any kind of hyperbilirubinemia and a need for RhoGAM. So when you are type A, so say your blood type is A, if you have this RH factor, it's this D antigen that they found after they figured out the A, B, and O blood types, they found this other antigen, the D antigen, I think in the 1940s or 50s. If you have it, 85% of the people in the world have it. So what that means is they're a positive blood type. So if you have type A blood and you have the Rh factor, you're A positive. If you're type A blood and you don't have the Rh factor, you're A negative. Where this comes into play is if you have a partner that is positive and you're negative, you could have a positive baby. And basically what your body would do as the woman is create antibodies, which wouldn't be a big deal with the first pregnancy. It doesn't really give you time to create the antibodies before the baby's born. But at birth, when that placental membrane is compromised and those bloods sort of come in contact with each other, the maternal and fetal blood, your body makes antibodies and remembers it. So if you had another positive baby or another baby with the Rh factor, your body would react and treat that baby as if it were an infection and be like, oh, well, I need to destroy this. I remember this. This is bad. I need to destroy it. It can be detrimental to the baby. There is something that we can do about it in RhoGAM. It's an Rh immunoglobulin. It's made from human blood products. We can give it to women who are Rh negative at about 28 weeks, and then we give it to them again if the baby's positive within 72 hours. And that just basically teaches the woman's body not to make those permanent antibodies, so subsequent pregnancies are not at risk for having any kind of immune response. That woman's body's not going to have such a immune response if we give her that immune globulin at about 28 weeks gestation, and then again if the baby's positive. There is something called an ABO incompatibility, which we'll talk about a little bit later, that really there's nothing that you can do about that. There's no medicine, there's no RhoGAM. You would watch those babies closer for jaundice and hyperbilirubinemia as well, or hyperbilirubinemia, which manifests as jaundice. But for an Rh woman, there's something that we can do, so that's why we check them. We check their blood type, we check their Rh factor. If they're negative, they're going to get RhoGAM at 28 weeks or so, and they're going to get it again if the baby is a positive blood type within 72 hours postpartum. So he'll also probably run a chemistry on the woman to determine renal function, baseline glucose. These are all first trimester labs. Rubella titer, you want to see a woman's immunity to rubella. If she's not immune, she'll be offered the MMR, the measles, mumps, and rubella vaccine postpartum. You want to educate women that that vaccine is live, and live vaccines can be teratogenic, so you want her to not become pregnant for about 12 weeks or so. HIV testing will be offered. VDRL or RPR determines active syphilis. Again, we talked about that. Syphilis can cross the placental membrane, can have detrimental effects on the fetus, so you always want to check that in the first trimester because it can be treated. HSV for herpes infections, hepatitis B. You want to detect active disease and any kind of immunity to hepatitis. Rubella is just listed twice. Glucose screening is usually done about 24 to 28 weeks gestation, because if you remember, we talked about HPL, that human placental lactogen. That placenta is not really big enough. It's sort of growing. It gets to the point, the size, and admits those hormones at about 24 to 28 weeks. So you want to see how women are doing with that insulin resistance, and if their pancreas is compensating or if they're getting that hyperglycemia, which would be seen in gestational diabetics. You're going to do a urinalysis, a urine culture, and then usually cervical smears, gonorrhea and chlamydia, and then group beta strep. Group beta strep is usually done in the third trimester, about 35 to 37 weeks. It's group beta strep. If a woman is GBS positive, she would get antibiotics in labor. It can be very detrimental to the fetus if a woman is group beta strep and not treated, or group beta strep and her membrane's ruptured. It's actually the number one cause of sepsis in infants. So that's always checked in the third trimester. If for whatever reason a woman doesn't get that test, or she's, delivers prematurely, most of the time, in my experience, they watch those infants more closely. They're going to have Q4-hour vital signs as opposed to Q8, and they're going to keep them in the hospital for 48 hours to really make sure that their temperature is stable.